Hey everybody, this is Dr. Caridi from the Austin Gynecomastia Center, and this is an on-the-fly video because I have a really nice guy today. He's from out of state, and he is a obvious bodybuilder type. And really what's super cool about him is my nurse, who's kind of keen to looking for kind of educational cases, talked to him about doing a video, and apparently without hesitation, he's like all down for this. And it's even more than that. What's really kind of cool in his particular case is that he knows that I really don't have a lot of sort of bodybuilding kind of videos out there, and there's a few reasons why you guys don't necessarily want to be videoed. But he also knows I'm also about the brotherhood. The brotherhood means this isn't marketing. This isn't like glorifying how wonderful we think we are or anything like that. This is about helping guys who have gynecomastia, okay? And what this video is going to be about is a little bit different than the other videos, okay? This is solely going to be about gynecomastia in bodybuilders, okay? Because there is a difference. And we're going to talk about this difference, and we're going to show you this video. And hopefully it'll just be sort of one of these epic educational videos coming from someone who does a fair amount of these and has a way of sort of articulating what this is all about. So we appreciate him 110%. So, voila. I walked into the room. Greatest thing about him, he looked at me and he smiled. Baby, greatest thing you can do to your doc. Just come on and give me a smile. This is all about being happy. I know it's a little bit nerve-wracking, but I got this under control, so you have nothing to worry about. So it just means that he's happy and he's kind of an upbeat guy, which is great. What I did notice is his posture. Immediately, it sucked, right? It just sucked. I mean, okay, and it's really common. And so my nurse is going to whip through the side over here a little bit, and we're going to talk about his posture. If you can see down over here, his shoulders come forward. He's got massive, great shoulders, and he flexed right here. So this is in deep right in this region over here. So you can imagine when you straighten out, look at that. Oh, boy. So shoulders are down and back, and this chest comes out here. And now he's got rocking pecs, okay? The reason why he does that and why everyone does is that when you do this, you're pushing this nonsense out, the gyno, and that's not cool. So what he does is what everybody does is a way to camouflage the whole deal is to assume that position, okay? But we need to be in the upright position. This is the way, you know, Mother Nature intended him to be. And he looks better, he looks more confident, all that kind of stuff. And the great thing is today his chest is going to be cleaned up, so he never has to worry about that again. Okay, so we're going to take this down. I'm going to ask you to lie back. Okay, so here we are. All right, can you have a marker? All right, so what do we see? Man, he's fit, okay? Great shoulders, delta pectoral muscles, biceps. This guy's rocking, okay? And I do a lot of bodybuilders from all over the world, and it's a privilege and an honor. And there's a difference between bodybuilders and the typical gynecomastia for this reason. Number one, they don't have a lot of fat. So I have to work in an environment that doesn't have a lot of fat. The implication of that is I don't have sort of stuff to work with that I would normally be able to work with, trying to get a nice, smooth, fine result. Number two is often they have gland. It's just rock. You know, a lot of these guys have taken hormones and supplements and whatever, and that makes the rock, okay? Now remember, gyno is gyno. Doesn't have to be rock. It could be anything else. It just is just the appearance of a female-like kind of deal in a guy, all right? But they have rock. Number three is they're bloody. They stick. In other words, the tissue is inflammatory. You can have pain because when you're taking these supplements, it gets this whole glandular stuff riled up and it gets inflamed. And when it gets inflamed, it gets sticky. And it gets sticky, it means that the dissection is a lot more challenging than it would be in ordinary circumstances. What that means for you is don't be that person that says, oh man, my stuff's not that bad, you know, blah, blah, it's well localized, blah. No, it's more complicated. And, you know, everyone, I can't tell you how many times I've been in that back operating room with, oh, this isn't so bad. And it's like, oh man, it's a pain in the ass. And so the important point for me is how to conduct the operation and do the procedure. Now, because of the extent of his stuff, it's all through here, okay? It's pretty big, bigger than you think. and for sure he's got gland, all right? Now, truth be told, what I'll do in some circumstances is I'll make just the incision up front here and take care of everything up front. But in his case, I'm also going to make a tiny incision up laterally here because I want to release all this glandular material with the vasor system, okay? So what I'm trying to do is separate this sort of inflammatory bloody mass from the surrounding area so then I can get my scissor here and pull it out. If I try to do that technique through the front end here alone, you're often going to get burns at this site, and then it's just not that cool. So the idea ultimately is for me to have the utmost respect for my weightlifting guys. I mean, they're particular. I mean, they're fastidious. That's what they work with their body, right? And it's all about appearances. So I'm just super focused on getting it just perfectly right. I mean, I'm like that with all my patients, but I have to triple down on my bodybuilders because this is what they do, man. They bodybuild. And so that's going to be our approach. We're going to get a fair amount of stuff on him. I can tell you also that I'm not going to leave gland in there so that there's no depression. I'm going to remove all the gland possible. I'm going to take a top-down approach. You've seen this in all my videos. So if it comes back, I tell all my patients, you come back, because I've never seen it. If you're leaving material in there so you don't have a depression, well, then you're still going to have puffy nipples. And then if you're still taking hormones, that stuff's going to regrow and you're going to get a recurrence. So now you can see, ultimately, I want him to have his cake and eat it too. We're going to get rid of all the material. We're going to leave the contour nice and natural. We're going to let his true pectoralis muscle shine through. We're going to give him that nice contour, no puffiness, nothing. We're going to get his posture rocking. And we're going to do this with minimal complications, which basically means avoid hematomas, avoid seromas, and all that kind of stuff. So that's really the essence of gynecomastia in a bodybuilder. It's a little bit different. It's a little different approach. We're going to pick this up in the operating room. I'm going to teach you even more. All right, so here we are in the operative setting. And I think you could probably see here a little bit better that you can see it up close here with that camera. You can see this mass moving under the skin here. You see that? And so the thing about bodybuilders is, you know, they take these supplements. You know, you get the gland, the real deal, and you can see it moving. See, it's stuck, and it's usually inflamed, and it's stuck, and it's bloody, and sort of the big issue with a bodybuilder is they don't have a lot of fat. And then when they kind of do that whole, what do they call it, where you
cutting
and stuff, I mean, you got like zero fat. So basically there's no room for error, meaning that they have to try to get the contour perfect, because then you're all about showing your body off, so we don't want to have a problem. So it just has to be done with much, much greater precision. And I can tell you, as a person who's done a few thousand gynecomastia case and has a real big practice with weightlifter kind of guys, this is something that you got to think about when you go to people. They really have to be qualified to do what they're going to do for the reasons that you're going to learn about in this video. And I told you about different approaches. Sometimes I just go up front, but in his case, I want to release a lot of this inflamed tissue with the vasor technique through a tiny incision over here, and then we'll remove the gland from a tiny incision down here, and we'll see his result on the table. This is not going to be something that's going to take forever. Okay, we'll get this on the table. I've done my vasor, ultrasonic liposuction. I've done my traditional liposuction. So I've removed some of the fluid that's around this mass. Now remember, very little body fat, typical bodybuilder, right? After I've removed this fat, some of the fat, and really done my ultrasonic work to prepare this for removal, what I'm left with is a mass. Okay, this little mass. You can see how it's stuck right there. You see how it's pinching the skin? So that you can see it moving. Look at it move under the skin. Woohoo! There's a mass. I'm going to take this mass out. Now, the reason why I'm wearing these is because it helps me be really particular about the dissection right here. So because I don't have a lot of fat to work with, I mean fat thinking of like I'm gardening and I'm running out of dirt because I want to make it nice and smooth. I got to preserve all the natural fat that he has, the non-gynecomastia fat that he has. and just take out the mass, the whole mass and nothing but the mass, the whole thing, top down. I'm going to show you how to do this in a minute. I use these loops, these glasses, to magnify everything and to light it up so that I'm more precise. Let's pop over here again and remind ourselves why this is a little different with bodybuilders. Look how little fat there is. There's no fat. So that's really not even fat per se there. It's mostly just the fluid that I put in there to do the ultrasonic liposuction. Okay, so table up, sir. So all the mass is removed. There's no question. There it is. There's no more white meat in there. This is all white meat. And the contour of his chest is actually pretty nice. Here's the lateral border of the pectoralis major muscle. Here's the nipple-areola complex, right? And it's nice and flat. All this tissue has been removed. See, there's nothing really under here I have to deal with. But now, as you could tell, it's just not a lot to work with, okay? So,
can you show us the muscle?
Yeah, so let me show you the muscle.
There we go.
Here's the muscle. All this dark stuff, that's muscle, all right? And this little layer on top here, you see this, folks? That's the fascia. Thin little layer, prepectoral fascia. And then sometimes I actually can have something to work with that'll help me out. In other words, I'd like to bring down some fat. Now, I see some fat up here, way up here, but that's pretty far away. Look how far away that is. I have a little gland here I'm going to go after, too. A little bit, boom.
And can you tell us how you know the difference between fat and gland?
Well, gland is that white stuff. Fat is this beautiful stuff here. Now, this is a nice layer of fat, and as you can see, I'm able to work with this. So I'm going to show you, hopefully, something pretty cool here. I'm going to separate this a little bit from the surrounding area. Because remember, I want to put a mattress of good tissue underneath the incision. So with a stitch my good nurse is going to give me, we're going to play with this, and it's just difficult. This is not routine, folks. There's nothing routine about this. These cases are more challenging. And I don't really have much fat to work with below here, so I'm going to grab some of that fascia. And you're going to see all this purpley color that you have here, and I'm going to tie this up and I'm going to take a look and see what happens. Okay, show me a little bit more on that more. Put it underneath the there you go. See, look at that beautiful fat. Okay, that fat is my friend. Totally. Okay, because that's what's going to be a buffer between the overlying tissue and the underlying muscle. Okay, so I'm looking around for some more beneficial material here. I like this. I got this piece of normal fat here as well. And I'm trying to work that down maybe with this little piece of fat right here. Again, I'm working to get some fat between the nipple-areola complex and the muscle so it doesn't stick down. I don't want to have a scar contracture in that area. Or we have an alternative, just leave some of that meat in there. So again, I'm trying to get your cake and eat it too. Trying to get you where you want to be without any issues. Okay, that's looking pretty good. That's looking pretty good. And that's looking nice and flat. So I'm pretty happy here in terms of being able to remove all that tissue. Again, I don't have a lot of fat to work with. I've done the best I could with what I got. I see a little bit of fat here. I think I'm gonna mobilize this a little bit if I can and swing it down. So I'm going to try to keeping the blood supply to this tissue here. Well, I'm trying to get it down. Not easy, folks, because remember, it doesn't have a lot of fat. So I'm doing the best I can, working with what I got, okay? And this is on the fly. You're seeing it firsthand. Welcome to my world. Okay, that was good. That was a good release there. Get a bite of this. Coming down here. Get a bite of that fascia. And watch this fat just move a little bit closer to where I want it to be. Look at that. Boom. Okay. Boom. Boom, boom, boom. And I know this seems like, oh well, not a big deal. No, it's a freaking huge deal. Okay. It's a huge deal. And I dare say how many surgeons out here are going to be able to do this, let alone sort of like, what is he doing? Well, there's a reason for my madness. Okay, that's pretty good. That's pretty good. Now you also know, for instance, why, okay, hold that there. Why I use these loops, folks, because this is small, right? And I wear my loops to make everything bigger, so I can work with it better, all right? All right, I see this little bit of fat here. I'll grab that island. Come on, take that out for a sec. I'm gonna move this down here. Coming up with this, down with that. You know, I'm just basically, this is on the fly, folks. This is basically doing what you gotta do. Take that out now to make this as good as possible. All right, good. All right, so I'm pretty cool with this so far. So we're done. I'm cool. I feel good. So let's just review this now. So I removed all that mass. All that mass is gone. This nipple is flat. There's no more gyno tissue underneath. That's completely gone. And notice that when I open this up, you see some fat, okay? See the fat? So the fat is what's gonna help us so that this is a smooth result and you don't have scar tissue. You don't want this to scar down to that, okay? But he doesn't have a lot left. So this is sort of like, you know, this is about as cool as it gets in terms of what we're up against. But I like the contour. This looks pretty awesome. We're on the other side now, okay, the patient's right side, which is the bigger side, and not to bore you with the details of a long video about removing this tissue, but yeah, the struggle is real, and we're working it out. This is why I have special glasses. This is why I have special experience. This is why I have a nurse that has extrasensory perception and knows where to pull and tug while I yank and cut. I mean, it's just unbelievable getting these things out. So I hope at the very least the video helps to say, hey, okay, let's stop with the myth that, oh yeah, it's small, Bob. It's small. Oh yeah, it's small. You're darn right. so I'm resting now because I just did what I did and you watched me suffer, so I hope you enjoyed that. I'm looking down here, I see the contour looks really good, I love that, and I know I removed the whole thing, so I'm almost home. But the problem is now what? I mean, I don't like to see this, okay? This is muscle down here, see this? And this is a little fascial layer on top. This thing was stuck to that, but I do see this little gift from heaven right over here. So be aware that more surgeons are sort of coming on to what I'm doing, and they'll tell you that, oh, yeah, look at this fat, like you put a little streak of fat there. Well, the fat has to have life, and that means a flap. And so what I'm reaching is over here. I'm like, woo, baby, we got lucky. All right, give me a little retraction here. I don't think you can use, that's too big. But I'm gonna free this up a little bit, and then I'm gonna take this island that has this blood supply, and I'm gonna get this vicral suture through here. I'm coming across the bend to some fascia over here. And remember, this is the bigger side too. So the bigger the mass, the more he won't have fat to deal with, right? Because it's just took up all the space, right? Okay, voila. All right, so we got that. That looks good. I got some fat in that area here. This nipple is nice. There's some stitches under here, so he's gonna feel those stitches. It's not that we left anything. I'm gonna have a complete video of this. And now you have to think too, is that when we're done in the weeks to follow, he can massage in this area here to kind of keep this from sticking down. Contour here is pretty awesome. We're gonna get a post-op video of him. I think he's gonna, when is he local? Is he out of town?
No, he's out of town, so we'll see him tomorrow.
We'll see him tomorrow. You get to see how his chest looks. It's gonna look fine. But I hope that this video really illustrates the difference between the typical sort of standard gynecomastia in my bodybuilding community. I haven't done a really good job kind of reaching out to you guys. We do you all the time. It's just that for some reason it never occurred to me that you want your own little kind of space, which I love, because that's what this guy said. Hey, Bob, you don't have a lot of, you need to have one of these videos. And I'm like, okay, good, let's just do you. And here you go. This is what we do all the time. We just don't really kind of go crazy about it. But it's different than everybody else. Please stop telling me it's nothing, it's small. No, it's more challenging than you think. We got to think about anesthesia-related issues, because this hurts, this is pulling and tugging and all that kind of stuff. It's stuck, it's glandular, it's more vascular, and there is no room for error, because I don't use the term error. There's just no room to really kind of work. It just takes far more precision, hence the loops and the magnification and all this kind of stuff, because in the end, he's a bodybuilder. He cares about, I mean, we all care about our bodies, but these guys are really into it, and it has to be done right. So, boom, voila. Hi, everybody. So here we are, the next day, you know, less than 24 hours. So this patient we did yesterday, and we pulled out a huge mass, and we're going to show you the mass here in a minute. But here was his chest before surgery, and he's a bodybuilder. So this video is all about my bodybuilding peeps, because what I clearly shown in this video is that it's a whole nother ball game with bodybuilders, and I think this is a great video that really illustrates the features that make them different than the ordinary types. So he is literally less than 24 hours gone. Look at this, great shape. You can see the nice outlining, great pecs. This is the area where the tissue was removed. It's red. It's this, it's that, but it's completely normal. You can see the lateral borders, pectoralis, major muscle, a little bit of swelling over here, but not that bad. I mean, his only bruising is really down over here. And so the thing that I also said in this video is that, that you're at higher risk for developing hematomas. He obviously doesn't have a hematoma, but these things tend to be more vascular, okay? So let's skip here, if you will, to this, which is like, hello, look at that. Okay, so, you know, you saw this yesterday. They saw this in the video, right? Mm-hmm. Yes, you guys saw this already, but here I am just reminding myself, because I've done about, 4 cases since him. But look at the meat that we got out of him. And the meat is the white stuff. And the white stuff is real, and this is generally hormone or pro-hormone induced stuff. It's usually gland. You don't get fibrous gynecomastia when you take that those substances. And this is how he's rocking. So he's got to take it easy, because he's got some flaps in there that I had to use to close things up after I removed this mass, okay? So he's got to stay away from his chest for about 2 weeks. He can do stuff elsewhere in about 4 or 5 days, but he's definitely got to stay away from his chest for 2 weeks, or he'll bust out those stitches. I haven't seen any problems with that so far, but I think that the reason why I tell him is so that he doesn't have the incentive to go out and try to bust my stitches, because he's going to be in another state, and then they'll be like, well, Bob, what's up? And I'm like, well, you know, you got to get your butt back here. But anyway, it's all good, and we're happy for him. I think he's happy, and I think this is a great case that just shows the whole idea of what a bodybuilder is and why they're a little bit different. And if you learn something from this video, that's a good thing. And he's actually super happy to help out everybody. If you have any questions or comments, just go to the bottom of the video and lay it out there. I know a lot of you guys use Reddit too, so get the conversation going on Reddit if you have any questions. The thing I know that disappoints you guys is that I don't know much, or I shouldn't say I don't know. I mean, I know a lot about a little, and I know a little about a lot, but I don't really get into the whole what your regimen is and how you're doing the regimen. That's really best suited for a board-certified endocrinologist, which I am not. So in other words, I don't get into the whole thing. All I can tell you is that if you do develop it, it's not going to go away. I don't care what you take, it's not going to go away. What diet, exercise, it just doesn't go away. You need to have a surgical procedure to make it go away. And the thing I tell all my patients too is after treatment, if you do all that stuff again, it's unlikely that it comes back, because it's all gone. As you can see, I don't leave anything in there. Okay, there's nothing in there per se that we left. It's all gone. So it's like having a car that has no engine. You know, I don't care what kind of gasoline you put in it. There's no engine, so you're not going to be able to drive it anywhere. So anyway, thanks for watching, and we appreciate everything. Thank you.